Good morning, ladies and gentlemen. This is a brief lecture on a histopathological feature. And the lecture is on cutaneous granuloma, cell types, and classification. I have already taken a detailed lecture on granulomatous inflammation. So this is just a part of that, your extension of that lecture in which I would be highlighting some different type of cells. So let's discuss the granuloma again. The granuloma is a medical term for an organized collection of histocytes that are trying to destroy a foreign substance. A special type of inflammatory reaction in both infectious and non-infectious diseases. The adjective granulomatous refers to a disease or an inflammatory reaction that is characterized histologically by granuloma formation. So all those diseases which are characterized by granuloma formation are called as the granulomatous infection, like cutaneous leishmaniasis, tuberculosis, deep mycosis. Or granulomatous disease when the infection is not there, for example, sarcoidosis or granuloma annulare. Granuloma. The granuloma is a relative, discrete, or organized collection of epithelioid macrophages. The plus and minus findings of granuloma are giant cells, non-epithelioid macrophages, lymphocytes, plasma cells, and fibroblasts. So the presence of these cells is not must for the diagnosis of granuloma. And secondly, the granuloma is always the discrete and organized collection of epithelioid cells, and no diffuse sheets of histocytes will be labeled as granuloma. There are certain causes of granulomatous inflammation. For example, a presence of insoluble foreign material like silica, asbestos, or talc. Such a foreign material will induce a foreign body giant cell reaction and granuloma formation. The granulomas are also formed when there is a limited resistance against microorganisms such as tuberculosis and actinomycosis. Some impairment of body defenses against acute infections like staph may lead to granuloma formation and the disease called as the botromycosis. Any factor causing delayed healing, for example, decreased blood supply or local nutrition, may also result in granulomatous inflammation. Persistent hypersensitivity, for example, in tuberculosis, may also result in accumulation of epithelioid cells leading to granuloma formation. The granulomas form in response to antigens that are resistant to first responder inflammatory cells such as neutrophils and eosinophils. Such antigens are most often infectious pathogens or a foreign substance, but often the offending antigen is unknown, as we see in autoimmune disorders. The macrophages and histocytes, which are the main cells of granulomas. Macrophages, also called histocytes, are cells that define granuloma. The other key term in above definition is the word organized, which refer to a tight or ball-like formation of these macrophages. Macrophages are typically so tightly clustered that borders of individual cells are difficult to appreciate within a granuloma. Loosely dispersed macrophages are not considered to be granuloma, and in histopathological reporting, we refer to them as ill-formed granulomas. Epithelioid cells. Macrophages become large, polygonal, with pale oval nucleus and abundant eosinophilic cytoplasm, and such kind of macrophages are called as the epithelioid cells. The epithelioid cells you can see here in this picture, these are elongated macrophages. These cells lack phagocytic activity and tend to arrange in group. Macrophage become epithelioid cells when it has not undertaken phagocytosis or extruded the phagocytosed material outside. Foamy histocytes. If macrophages are unable to extrude the phagocytosed material, for example, a lepra bacilli in lepromatous leprosy or ingested lipids in xanthomatosis, the histocytes become foamy, but does not become epithelioid. So the foamy histocytes are mainly seen in lepromatous leprosy and in xanthomas. There is a slight difference in between the two. In lepromatous leprosy, there is a gran zone beneath the normal epidermis and the sheets of foamy macrophages, while in xanthomas, there will not be a gran zone. Further, although the macrophages will be distributed, foamy macrophages will be distributed in sheet form in lepromatous leprosy, there will be a hint of granuloma formation somewhere, or there will be some entrapped nerve bundles within these sheets of macrophages. This feature will also be absent in xanthomatosis. Additional cells in granulomas. All granulomas may contain additional cells. For example, lymphocytes, neutrophils, eosinophils, plasma cells, and fibroblast. The additional cells may sometimes be a clue for the cause of granuloma. For example, granuloma with numerous eosinophils are seen in coccidioidomycosis. Granuloma with numerous neutrophils are seen in deep mycosis, atypical mycobacteria, and in Wagner granulomatosis. The plasma cell-rich granulomas are usually infectious in origin, like tuberculosis and cutaneous leishmaniasis. The granuloma can be low turnover or it can be high turnover. The low turnover granulomas are mainly because of foreign material. The rate of proliferation and recruitment of macrophages from blood monocyte is slow in low turnover granulomas. While in infectious granulomas, like BCG vaccination, macrophages live for a short period in the tissue and are continuously replenished by the blood monocytes. Granulomas may be classified as infectious and non-infectious. The infectious granulomas include tuberculosis, leprosy, granulomatous syphilis or the gummatous syphilis, deep mycosis like histoplasmosis, cryptococcosis, coccidioidomycosis, and blastomycosis. The non-infectious granulomas mainly seen as sarcoidosis, in Crohn's disease, in berylliosis, in Wagner granulomatosis, and Sjögren's, which are the granulomatous vasculitides. Another important feature of granuloma is that whether they contain necrosis or not. A related term is caseation, which refers to a form of necrosis that appears cheese-like and is typical but not uniquely a feature of tuberculosis. So classically, the caseation necrosis is seen in tuberculosis, but sometimes it is also seen in cutaneous leishmaniasis. Granuloma with necrosis tend to have an infectious cause. So it is not possible to have necrosis in a granuloma if it is not infectious. Then giant cells. Giant cells are usually important to stress that giant cells do not have to be present in a granuloma to meet its criteria. However, the presence of giant cell in a granuloma helps in picking up the granuloma histologically. There are different types of giant cells which are seen in granulomatous inflammation. The two typical types of giant cells are the foreign body giant cells. In foreign body giant cells, the nuclei are arranged haphazardly within the cytoplasm, while there is second type is a Langhans type of giant cells in which the nuclei are arranged in horseshoe-shaped pattern. Langhans type of giant cell is prototype of tuberculosis and related disorders. Sometimes it is also seen in cutaneous leishmaniasis. Then two-tone type of giant cells seen in xanthogranulomas, in other type of xanthomatous disorders like reticulohistiocytosis. And two-tone giant cells is characterized by a large giant cell in which there is a central dense zone of cytoplasm in which the nuclei are arranged circularly, which is called as the wreath-like configuration. Wreath are the florals which are usually presented on a grave in a ceremony. Then surrounding this wreath-like configuration of nuclei, the surrounding cytoplasm is foamy in nature. So this is a two-tone giant cell. Then osteoclast-like giant cells are seen in osteoclastomas and also seen in some other solid organ tumors like in liver, pancreas, and lungs. And these are like foreign body type giant cells. Morphologically, the granulomas in skin are usually characterized or classified as the sarcoidal granulomas, which are usually also called as the naked granulomas, then tuberculoid granulomas, then necrobiotic or palisading granulomas, suppurative granulomas, and foreign body type granulomas. The sarcoidal granulomas are characterized by very discrete collection of granulomas, which have very well demarcated boundaries. There are few lymphocytes or plasma cells, so they are mainly called as the naked granulomas, and the giant cells typically are the foreign body type giant cells. Mainly the sarcoidal granuloma are seen in sarcoidosis and in foreign body, which can be of crystal or non-crystal origin. Then the tuberculoid granulomas are characterized by less circumscribed granulomas with greater confluence. And there is dense perigranulomatous inflammatory infiltrate comprising of both acute and chronic inflammatory cells. The giant cells are mainly of Langhans type of giant cells. Caseation necrosis may or may not be seen. Tuberculoid granulomas are seen mainly in most of the infections or infected granulomas, like in TB, in leprosy, in syphilis, and in leishmaniasis. Some other non-infectious causes like granulomatous rosacea, perioral dermatitis, Wilkerson-Rosenthal syndrome, acne egbenita, and Crohn's disease also characterized by tuberculoid granulomas. The suppurative granulomas, in which the area of suppuration is present surrounded by granulomatous inflammation and then rim of inflammatory cells, it is seen mainly in deep fungal infections and in atypical mycobacterial infections. So usually if we do a PS stain or Grocott stain, we can find these hyphae and spores within the zone of suppuration. Necrobiotic granulomas are seen in necrobiotic disorders characterized by a zone of altered connective tissue with blurring or loss of definition of collagen and increased basophilia and variable mucin deposition. And surrounding this zone of necrobiosis, there are ill-formed granulomas in which the epithelioid cells are arranged radially in form of palisades. Multinucleated giant cells are also seen. In foreign body granulomas, you can see a foreign body surrounded by foreign body type of giant cells. So here, these are the foreign bodies and there is a granulomatous reaction. So all kind of foreign bodies can result in the foreign body type giant cell reaction. It can be extrinsic like starch, talc, tattoo material, wood splinters, suture material, or it can be endogenous like hair, like and etc. To determine the foreign material, we use the polarized microscopy or X-ray dispersive microscopy. Endogenous material include calcium oxalate crystals, urate crystals, keratin, or hairs. For a granulomatous inflammation, the usual approach is first to find the type of granulomas, whether it is sarcoidal, tuberculous, necrobiotic, or suppurative. Then determine the type of cells present in the granulomas, including the giant cells. Then we do some polarized microscopy to find a foreign body cells. Then special stains like Ziehl-Neelsen stain for tuberculosis, PS stain for fungi, Gram stain for bacteria. Sometimes we require it in actinomycosis or actinomycetoma. They are also time consuming and requires multiple slides. CD1A and Giemsa stain is done mainly for cutaneous leishmaniasis. CD1A is currently a very popular stain and it highlights antibodies beside highlighting other things. Negative stains does not rule out any infection. So we can proceed for cultures. We can go for PCR and other laboratory and immunological profiles. Then I would like to briefly discuss an important type of cell which we sometimes encounter, and these are the Russel bodies. Russel bodies are eosinophilic, large, homogeneous immunoglobulin containing inclusions usually found in plasma cells undergoing excessive synthesis of immunoglobulins. And the Russel body is characteristic of a distended endoplasmic reticulum. These are the characteristic Russel body, the pink or round bodies, and these rest are the plasma cells. This is our Russel body, this is a Russel body, these two are Russel body, this is a Russel body. You can see the Russel bodies here. And these are few Russel bodies which we see in plasma cells. These are the Russel bodies usually seen in the disorders in which the plasma cells are in abundance. I thank you all for a very patient listening.